Bones are not just structures, they are living engineering systems designed to withstand enormous forces. Biomechanics helps us understand how these forces shape fractures and guide surgical fixation. Biomechanics is a key topic for the Orthopaedics Intermediate exams. If you understand biomechanics, you understand how and why implants work. Whether it's screws creating compression, plates resisting bending, or external fixators stabilizing fractures. It's not just theory. Biomechanics explains how forces act on bone and how we control them to achieve fracture healing. Before we understand fractures, implants, or fixation, we must understand the basic forces acting on bone. There are three main forces every orthopedic surgeon thinks about. First, compression. This is a force that pushes or squeezes structures together. Think about standing or walking, your body weight compresses the bones. In fracture healing, controlled compression actually helps bone unite. Second, tension. Tension is the opposite. It pulls structures apart. Imagine pulling on a rope from both ends. In the body, muscles and tendons create tension forces on bones. Third, shear. Shear occurs when forces slide past each other in opposite directions. This type of force is particularly dangerous for fracture stability because it tends to displace fragments. Understanding these three forces, compression, tension, and shear, is the foundation for fracture patterns, implant design, and fixation strategies in orthopedics. Force is a fundamental concept in biomechanics defined as the product of mass and acceleration. It is crucial to understand that force acts as a vector, possessing both magnitude and direction. This understanding allows us to analyze how forces influence bone behavior and ultimately informs effective treatment strategies in fracture fixation. Another important aspect of this topic is the concept of moments and rotation. The concept of moments in biomechanics refers to the rotational effect produced by a force acting at a distance from a pivot point. The equation moment, you have force x moment arm, indicates that a larger moment arm results in a greater rotational force, which is crucial for understanding how forces affect bone stability during fracture fixation. Now let's quickly understand stress and strain. Stress is the force applied per unit area, written as sigma equals F over A. Strain is the amount a material deforms when that force is applied, expressed as change in length over original length. On the stress-strain curve, materials first behave elastically, meaning they return to their original shape. But once the elastic limit is exceeded, permanent deformation occurs, and eventually the material fractures. These principles help us understand how bones deform and break under load. This brings us to the concept of Hooke's law, which states that stress is directly proportional to strain within the elastic zone of a material. This means that as the applied load increases, the deformation produced in the material also increases linearly, provided that the load does not exceed the elastic limit. Once the load is removed, the material returns to its original shape. Deformation of materials refers to the change in shape or size of a material when a force is applied. When stress is applied to a material, it responds by deforming, which we measure as strain. Initially, deformation occurs in the elastic region, where the material returns to its original shape once the force is removed. If the applied force exceeds the yield point, the material enters the plastic region, where deformation becomes permanent. With further stress, the material eventually reaches its ultimate strength and finally the breaking point where failure occurs. Understanding deformation is essential in orthopedics because bone and implants must withstand forces without permanent damage or failure. Material failure in biomechanics refers to the point at which a material cannot withstand stress and yields to deformation or fracture. It encompasses concepts such as ultimate strength, breaking point, and fatigue failure. Recognizing these factors is crucial for effective fracture treatment, allowing for the development of robust fixation methods tailored to withstand expected loads. One of the cool features of bone is that it is anisotropic, meaning its mechanical properties vary significantly depending on the direction of the applied forces. This characteristic is essential for understanding how bones behave under different loading conditions. Cortical bone provides strength and support, while trabecular bone absorbs shock, demonstrating the complexity of bone structure and function in orthopedics. Bone is strongest in compression, allowing it to withstand significant loads during activities such as walking and running. Conversely, it is the weakest in tension, meaning it cannot handle pulling forces effectively. This disparity in strength is vital in understanding fracture patterns and the principles behind effective fixation methods in orthopedic treatments. A butterfly fracture occurs when a bone undergoes bending forces, leading to a tension crack on one side and a compression wedge on the other. This type of fracture is characterized by a distinct butterfly-shaped fragment that results from the combined effects of tension and compression during the bending process. Understanding this mechanism is crucial for effective treatment. Before we talk about fixing fractures, we need to understand implant biomechanics, the science behind how orthopedic implants stabilize broken bones. There are three fundamental tools surgeons use: screws, plates, and external fixation. Let's break them down. First, screws. Screws are the basic building blocks of fracture fixation. Their main job is to compress bone fragments together, creating stability and promoting bone healing. In some fractures, especially small or simple ones, screws alone may be enough to hold the bone in place. Next, plates. Plates act like an internal splint attached to the surface of the bone. They are fixed with screws and help convert tensile forces into compression, stabilizing fractures that cannot be controlled by screws alone. Plates are especially useful in long bone fractures or areas where stronger support is required. Finally, external fixation. Unlike plates and screws that sit inside the body, external fixators stabilize the bone from outside the limb. Pins are inserted into the bone and connected to external rods. This technique is commonly used in severe trauma, open fractures, or when soft tissue damage makes internal fixation unsafe. So, in summary, screws compress, plates bridge and support, and external fixation stabilizes from outside the body. Understanding these principles is the foundation of modern fracture management in orthopedics. The pull-out strength of a screw is critical in ensuring stable fixation. It is influenced by bone density, which provides the necessary grip, thread length that allows deeper engagement, and diameter affecting the load distribution. Understanding these factors is essential for optimizing implant performance and achieving successful surgical outcomes in fracture fixation. As I mentioned in the previous slides, plates function as tension bands. They convert tensile forces into compressive stabilization across fractures. This mechanism is vital for effective healing. However, empty holes in the plate can lead to increased stress concentration, potentially compromising the fracture site. Understanding these dynamics is essential for optimal implant selection and patient outcomes in fracture fixation. That being said, let's talk about locking plates. Traditional plates depend on the plate pressing against the bone to create stability, but locking plates work differently. In a locking system, the screw head locks directly into the plate, creating a fixed angle construct. This means the plate and screws behave like one solid framework. Instead of squeezing the bone tightly, the plate acts more like an internal external fixator. What does that mean clinically? It means we can maintain stable fixation even in difficult situations such as osteoporotic bone, comminuted fractures, metaphyseal fractures. Because the stability comes from the plate-screw interface, not from the plate pressing against bone. As illustrated by the diagram on my left, a few methods have been documented to improve the stability of external fixators. These, amongst others, includes increasing the pin and bar diameter, thereby providing greater support. Additionally, minimizing the distance between the bone and bar enhances stability. Employing pins in multiple planes further distributes the forces, leading to a more robust fixation system that effectively manages complex fractures. Every step you take, your hip joint carries up to 5 to 8 times your body weight. Yet this joint moves smoothly for decades. So how does the hip survive such enormous forces? Today we break down the biomechanics of the hip joint in simple terms. The hip joint is a ball and socket joint formed by the femoral head and the acetabulum. It provides both stability and a wide range of motion. During normal walking, the hip experiences forces up to 5 to 8 times body weight. When standing on one leg, body weight creates a downward force on the pelvis, while the abductor muscles generate an opposing force to keep the pelvis level. Because the abductor moment arm is shorter than the body weight moment arm, The abductors must generate much larger forces to maintain balance. This results in a large joint reaction force across the hip. Biomechanically, the hip is designed to handle these loads through a deep acetabulum that increases stability, strong trabecular bone that distributes stress, powerful surrounding muscles that control movement. Understanding these principles is essential in hip fracture fixation and prosthetic design. As we conclude, remember that biomechanics is the foundation of fracture management. Understanding how forces act on bone and implants helps us explain fracture patterns, choose the correct fixation, and prevent implant failure. Mastering these principles will not only help you succeed in the intermediate exams, but more importantly, will guide your decisions in clinical orthopedic practice.